Hi, my name is Megan Michelson. Nursing in the operating room can bring ethical dilemmas that are not commonly seen in other areas of nursing. One major barrier in this area of nursing is that the vast majority of the time spent with patients are while they're under general anesthesia. Therefore, it's important to make sure that informed consent is received prior to bringing the patient back to the surgical suite. As nurses, we are able to witness a patient has signed an informed consent. However, we are only witnessing the signature, and it is the responsibility of the surgeon to speak with the patient prior to the procedure and ensure that they understand what is being done and that the patient does not have any questions or concerns. Usually, the form is confirmed by both preoperative and perioperative nursing staff prior to the patient arriving in the surgical suite. There are some instances, depending on hospital, where this is not the case, such as an instance of an inpatient having a procedure done that is on contact isolation. To reduce the risk of spreading infection, this patient would be taken directly from their inpatient room and brought to the surgical suite, therefore skipping the preoperative area. The specific situation that I had witnessed was compounded by the fact that the patient was not able to give consent and his medical decisions were instead made by his wife. The situation is covered by Provision 1-4, as the patient was deemed incompetent due to dementia and hypoxia, allowing the surgeon to discuss consent with his medical power of attorney, his wife. The situation is covered in Provision The circulating nurse accompanied the surgeon to speak with the wife and transport the patient. This forms a transprofessional relationship, which is common in the surgical suite, but was also beneficial in this situation as the nurse was able to know that informed consent was received and the medical power of attorney did not have any questions regarding the procedure. Once the patient was brought into the surgical suite, he was prepped for surgery, placed under anesthesia, and a timeout was performed. At this time, it was noticed that there was no hard copy of the informed consent signed. While the surgeon did go over the procedure with the power of attorney, the form was never printed or completed. The surgeon said he received consent from the wife and was comfortable with starting the procedure. But as nurses, we operate through Provision 2-1, acting in the best interest of the patient, and Provision 3-5, acting on questionable practice. While 3-5 may be applied more often to an impaired medical professional, such as someone under the influence, in this case his practice was questionable because he was willing to operate without having an actual informed consent, which could easily cause a lawsuit. The circulating nurse who was present with the surgeon explained the procedure to the wife, left the surgical suite to obtain informed consent from the wife. The scrub nurse stayed in the surgical suite and managed the surgical instruments to ensure that the procedure was not started until the circulating nurse returned with the informed consent. Had the patient been competent, the nurse would have refused to start the procedure until the patient woke up from anesthesia in order to ensure that the consent was signed as needed, even to the extent of getting backup from the charge nurse or from department managers. Informed consent is a major ethical issue that can occur in operative services, but following Provisions 1-3, 2-1, and 3-5 to always act in the best interest of the patient will help nurses avoid ethical issues regarding consent. Thank you.